Bismillahirrahmanirrahim. Welcome to you. I'm Dr. Muhammad Talat, Assistant Professor of Radiology at University. I hope you enjoyed our course, and we have today two interesting cases. The first case, this is a young adult patient who was presenting with slight deterioration of the conscious level. Non-contrast CT scan of the brain was done for the patient, and please remember this point. We did for the patient non-contrast CT scan of the brain. Look for the internal carotid arteries. These arteries are not enhancing, so it is non-contrast CT scan of the brain. As you can see here, the obvious abnormality is an irregular shape intracerebral hematoma, subcortical in location, and this hematoma is located in the right temporal region, and this hematoma is surrounded by hypodense brain edema. This hypodense brain edema is characterized by finger-like projection, so we are dealing with pathogenic brain edema, and this edema exerts mass effect in the form of the effacement of the cortical subsign. Also, slight compression on the trigone of the right lateral ventricle. And please, if you are not familiar with the causes of the intracerebral hematoma, please review our last videos. We reviewed together that we have different causes for the intracerebral hematoma, either traumatic or non-traumatic. In this case, there is no history of trauma, so this one is not cerebral contusion. It's not traumatic intracerebral hematoma. So let us think together what are the causes for the non-traumatic intracerebral hematoma. Non-traumatic intracerebral hematoma, we have primary and secondary. Within the secondary causes, maybe underlying vascular malformation. Maybe it's very common in the young adult patient. But please don't rush or don't go to the causes before finishing your checklist. Please, if you didn't see also CT brain checklist, please review this video. It's present in the first video of this course. If we start to check the checklist of the brain, we will go point by point, and within these points, checking the dural venous sinuses. It's very obvious to have dense cord sign within the straight sinus. This straight sinus should be isodense in the non-contrast CT scan of the brain, but here the straight sinus is hyperdense. By checking the other dural venous sinuses, you will find that the superior sagittal sinus is hyperdense as well. Even it is hyperdense. So cord sign is indicating that we are dealing with acute dural venous sinus thrombosis. The transverse sinus, more or less, isodense on both sides. I'm not sure is it thrombosed or not. The internal jugular vein is not hyperdense. So our sure findings that we have dense cord sign within the straight sinus and the superior sagittal sinuses. If we concentrate more for the other findings, this is the left Sylvian fissure. The right Sylvian fissure is totally obliterated by hyperdense materials. Also, the extra-axial CSF species on the right side is obliterated by hyperdense elements as well. Is it subarachnoid hemorrhage? Maybe. But the logic thinking that this one may be pseudo-subarachnoid hemorrhage. Pseudo-subarachnoid hemorrhage can be caused by cortical vein thrombosis and engorgement. This is the logic finding that if we have dural sinus thrombosis, maybe the cortical veins are thrombosed as well, and can give us a similar picture of subarachnoid hemorrhage or pseudo-subarachnoid hemorrhage. So the logic thinking or the logic diagnosis in this case is that we have acute venous thrombosis of the dural venous sinuses and cortical vein thrombosis and engorgement, and this venous thrombosis is complicated by intracerebral hematoma that is surrounded by pathogenic brain edema, as you can see here. Our second case today, non-contrast CT scan of the brain, and let us review the case together. The obvious abnormality is located in the right temporal region, and this abnormality It's a form of hypodense brain edema, which shape in configuration, cortical and subcortical, with loss of gray-white matter interface. And this brain edema exerts mass effect in the form of effacement of the related cortical sulci, also compression of the trigone of the right lateral ventricle. So this hypodense area most likely cytotoxic brain edema. Within this brain edema, we have intracerebral hemorrhagic component. Also, this one is hyperdense hemorrhagic component. We have two possibilities here, either hemorrhagic transformation of cerebral infarction or hemorrhagic venous cerebral infarction. We can differentiate between two possibilities by reviewing the history and clinical data, reviewing or checking the electronic medical file. We didn't find that the patient is receiving anticoagulant therapy, and at the same time, if we start to check other findings in our checklist, we will find it's more obvious to have distended right transverse sinus, and this distended right transverse sinus appears hyperdense. So it is suggestive of acute dural sinus thrombosis. Even the sigmoid sinus also is hyperdense. The internal jugular vein is hyperdense as well. This is the internal jugular vein as compared to the left side. So we have for sure evidence of dural venous sinus thrombosis. I think also the cortical vein here is thrombosed as well. So this is most likely acute hemorrhagic cerebral venous infarction. My message here is that sometimes dural venous sinus thrombosis is not so obvious, as you can see here in this case. Sometimes the only abnormality can be here, hyperdense cord sign within the internal jugular vein. So this one is very important, and you should review this data in every non-contrasted scan of the vein, especially if you have a form of cytotoxic brain edema. Let us end by some important tips. We have different terms here to differentiate between these points. We have hemorrhagic transformation of cerebral infarction. That means that the patient had cerebral infarction, then the patient was received anticoagulant therapy, and this condition was complicated by hemorrhagic transformation of cerebral infarction. The second term, hemorrhagic cerebral venous infarction, most likely venous or dural venous sinus thrombosis can be complicated by cerebral infarction, and most likely venous infarction. Most likely in many cases, it is hemorrhagic from the start. And we have also intracerebral hematoma, secondary to dural venous sinus thrombosis. And as we discussed before, that we have many causes for the intracerebral hematoma. We have secondary causes, and one of these causes is venous sinus thrombosis. Intracerebral hematoma most likely is surrounded by pathogenic brain edema. Hemorrhagic cerebral venous infarction, sometimes it's mixed between cytotoxic and pathogenic brain edema, but it's mainly cytotoxic brain edema. Hemorrhagic transformation of the cerebral infarction, the history and the clinical data is very important. We need to check, is the patient receiving anticoagulant therapy or not? In the management, it's very important to differentiate between these items, because hemorrhagic transformation of cerebral infarction, the anticoagulant therapy should be stopped. Hemorrhagic cerebral venous infarction and intracerebral hematoma, secondary to the dural venous sinus thrombosis, both of these items, the anticoagulant therapy should be taken to dissolve the venous sinus thrombosis and recanalize the dural venous sinus. So it's very important to differentiate between these items, and I would like to thank you all, and I hope you enjoyed our lecture today. Thank you so much.